نبدأ على بركة الله. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everybody. I'm delighted to start this session of the general topics. Very happy to have 6 participants today from different countries. And of course, we are pleased and we would appreciate the time of the panelists to be with us and join us for discussion and evaluation. So we will start now with the first speaker, Dr. Muhammad Al-Imari. He is already sharing his screen. He will talk about the topic of the non-invisible, and Dr. Al-Imari will be discussed by Ustaz Dr. Mahmoud Shitewi and Ustaz Dr. Sana Muhsin. So just general instructions as I sent to the participants today, that you have 12 minutes. When we say start, you have only 12 minutes. You have to finish within 12 minutes. And then there will be 5 minutes discussion. So you can start now, Dr. Muhammad Asim Al-Imari.
Thank you, Dr. Mazen. Thank you, everyone here. And a special thanks to Dr. Mahmoud Shitewi, Dr. Sana Muhsin, my panel. My topic today is named the non-visible, how to be a good observing ophthalmologist. Let's go through this. Actually, the non-visible is not the same thing like the invisible. The invisible could not be seen, while the non-visible is a thing that could be seen, but it is usually overlooked. So through this, the literature usually focuses on either examination techniques or examination findings as 2 separate isolated categories. So the literature itself does not suggest a consistent method to detect the signs regularly through these examination techniques. Here I suggest an idea, which is getting used to see the non-visible regularly helps building and maintaining good observation skills. So how could we develop this? My aim is to develop an objective manner to measure the effectiveness of one's examination techniques to consistently detect signs. This is for me as a person, but also for my colleagues, it is probably a reliable training method for refining observation skills in the rising ophthalmologists they are supervising in their training. To achieve this, actually, one should have interest, time, good examination techniques. With any one of these 3 missing, actually, you cannot develop your observation skills as you aim. So you should have sufficient interest, sufficient time looking at things, and good examination techniques. So I suggest that we develop a list of commonly missed ocular structures and or signs. They are always there, but they are always missed and no one stopped by them. So looking at these non-visible ensures a very low threshold of detecting signs for every ophthalmologist. Also, I suggest this list includes signs that cover at least one non-visible in every subspecialty, so that the focus is not only in one's subspecialty of interest, but at the same time, it has signs that he or she is interested in. So I suggest a list of signs that, yes, it covers some signs that you should be interested in, but also there are signs that are away from subspecialty of interest to ensure that you are still good observing ophthalmologist, not only in your subspecialty, but as an ophthalmologist. So I will give now 10 examples. By the end of these examples, we will summarize together what I mean by. The first thing is the caruncle and the plica semilunaris. Do you remember the last time when you stopped by this? The caruncle is normal or inflamed. You may remember that inflamed caruncle is included in the activity score of thyroid eye disease. Is this caruncle excised and replaced by like Lister-Jones tube, or it is keratinized as it is the case in ocular cicatrizing diseases? The second thing is the RBCs. When was the last time you noticed the RBCs moving in the conjunctival vessels? Many of us actually may not know that in every single patient, if you ask the patient to look upwards, you increase the magnification, you can see the RBCs flowing. You can even detect the direction of flow if either it is towards the cornea or it is away from the cornea. The third thing that I suggest is it is at the limbus. So the limbus is a very important area which is mostly overlooked. I focus on this limbus and I will suggest three things. This is the first one. The corneal nerves. The corneal nerves actually penetrate through the corneal limbus, and the cornea is the most densely innervated tissue in the body. So looking at these nerves actually present in every single patient. It is mostly overlooked. Why? Because someone says it is normal. Yes, it is normal, but seeing this helps you to have a very low threshold of seeing the fine things. So these corneal nerves are normal at the periphery, or it reaches the center, so it may be a prominent corneal nerve that indicate ocular or systemic disease. Also, I suggest looking at the palisades of Vogt. It may not be as pigmented as it is in this picture, but yes, it is very important to notice the palisades of Vogt where the limbal stem cells resides. So if this palisades of Vogt is disturbed, there is vascularization, conjunctivalization, anything disturbing this may be an early sign of limbal stem cell deficiency. It is a sight-threatening condition. Again, at the limbus, you may see the Schwalbe's line. The Schwalbe's line itself is mostly hiding at the angle, and you cannot see it unless you have a gonio lens. But in my area, and I think in many areas, as the literature says, it is present in 15% of the population. There is anteriorly displaced Schwalbe's line, which we call the posterior imperiotoxin. So is it isolated? Is it in Alagille syndrome or Axenfeld-Rieger syndrome? Then at the limbus also, you may be interested to look at the anterior chamber depth. The limbal anterior chamber depth is very important to the Van Herk technique to assess the risk of angle closure. We move now backwards. So the epicapsular stars. The epicapsular stars represent remnants of the pupillary membrane. It has characteristic like shape, but it is not pigment dispersion. It does not indicate an old attack of uveitis. So you should differentiate these minimal things. Also, a thing related to this, and I did not include in my presentation, the filaments of remnants of persistent pupillary membranes that are crossing the pupillary borders. So I usually train myself and my colleagues to look from where it starts and where it ends. It helps to see again the fine details. After the lens, you can see the anterior vitreous. Most of us, after the patient is dilated, we look at the lens to detect the cataract, and we did not look at the anterior vitreous. We just hold the 90 diopter or the 79 diopter lens to look at the fundus directly. The anterior vitreous is again very important to look. If it has like RBCs and vitreous hemorrhage, pigment cells in retinal breaks, and white blood cells in case of vitritis or vitreous inflammation. In the retina, again backwards, do you agree with the literature that the spontaneous venous pulsation present in about 90 to 80% of the population? If you are not agreeing with the literature in this, I suggest you keep yourself looking at the optic nerve head to about 3 to 5 seconds. You can notice, yes, in about 80% of the population. Some ophthalmologists suggest that you press on the globe. Actually, I do not believe this should be the case because it is no more spontaneous. Spontaneous venous pulsations, yes, present in 80% of the population if you have enough time, interest to look at the optic nerve head, and it helps you to differentiate between papilledema and pseudopapilledema. Yes, it may save you resources doing like B-scan, doing OCT, doing neuroimaging, because if you see the spontaneous venous pulsation, it is very unlikely. Yes, there is diurnal variation, but it is very unlikely that this is papilledema. This may be pseudopapilledema. And the last thing here in my list is the vortex veins. The vortex veins represent the cornea, the retinal equator. If you claim that you see the retinal periphery while you are not reached even the vortex veins, you actually did not reach the retinal periphery, because posterior to this is the posterior retina and anterior to this is the pre-equatorial retina. And here is the 10 examples I suggested: the caruncle, the conjunctival, blood flow, the corneal nerves, palisades of Vogt, posterior imperiotoxin, limbal anterior chamber depth, epicapsular stars, anterior vitreous, spontaneous venous pulsation, and vortex veins. We have limitation here. If I'm making this list to assess myself, actually, as we say in Arabic, but actually it is not the case if you are training someone. So if you are training, yes, it is objective. But if you are assessing yourself, it is more subjective. So yes, it is subjective, but testing yourself is a known manner to improve your knowledge. If you like enter the American Academy of Ophthalmology website, there is test yourself. So yes, it is subjective. The next thing, to increase the possible impact of this method, I'm inviting ophthalmologists to collaborate and develop either a score that could be incorporated in the software systems based on the data you enter. So you commented on the caruncle, let's say this is score 1, and by development of this score, we can say that above a certain number, this is a good observation or excellent or bad, and like this. The second thing, we can develop like a sheet through which the trainer could ask the trainee to fill after patient examination to see how much findings he or she can detect. My message here is to master the tools you have, give yourself time looking at fine details, and keep wondering repeatedly is a way that adds some joy to your hard work. Additionally, and in fact, more importantly, you can identify what might be missed by others so that you recognize early and mild forms of possible threats to sight and life. And thank you.
Thank you very much, Dr. Muhammad. Now, we will open the discussion, and we will start with Dr. Mahmoud Shtewi.
Okay, thank you very much, Dr. Mohammed Al-Amari, for your nice presentation. Yeah, but I just want to ask for two things. What do you find yourself now from these 10 points that you mentioned? Do you think it's benefit for candidate to use for ask and advise, or what's the aim? Sorry.
Yes, as I mentioned, the aim here is two things. For myself, to develop and maintain high level of observation. By detecting very fine details, we lower the threshold of detecting signs. I do not wait for the anterior chamber cells reaction to be +4 to be seen. I want to detect it when it is half. So to gain this, I should train myself to notice very fine details. And this is the first thing. The second thing, in training, I find these 10 things very, very beneficial for training the rising ophthalmologists. It has no direct benefit. Yes, you can say that why I look at the corneal nerves if it is normal, but it trains them to see very fine details. So they can easily, after this, detect mild forms of ocular signs. These are my
aims. The difference? Sorry, what's the difference with your 10 points that you mentioned in comparing to classical study or classical teaching? Because if I ask the patient, one student or just training, start to see with the slit lamp, it's much better if I ask him how to use the slit lamp and the application of slit lamp, how to use the beam and magnification. That will be much more teaching, but the things in the non-visible and these visible, I don't know why you took this name.
Yes,
this, it looks for me as a little bit complicated for this anyone just starting.
Thank you. I totally respect your opinion, doctor. But as I said, this good examination techniques is a prerequisite to can detect these things regularly. I think good examination techniques itself is not sufficient to regularly detect signs. Why? Because it has no objective manner in measurement. I can learn, let's say, how to use the direct and the indirect examination techniques, the sclerotic scatter, but we cannot know for sure if we are using these methods regularly or not. So by including some findings that are very fine, each one uses a different examination technique and a different part of the eye. This ensures, again, that every doctor maintains a very low threshold for detecting the signs.
But I think if I'm still thinking, if you think observing, you should observe his movement. If he has normal head posture or the toes or something like that, it would be more obvious and much.
Yes, good examination techniques is a very essential part. But
thank you.
As I said, this does not replace examination techniques.
Yeah, Mohammed, your point is clear. Thank you. Dr. Sana.
Thank you.
Thank you, Dr. Mohammed, for this nice presentation. I was actually hoping secretly that I would get to discuss this particular talk. I was actually very happy to see that somebody chose such a topic that is a little bit out of the box. As an anterior segment surgeon, I always tell the residents that we need to look at the anterior segment with more detail than we're used to, especially, for example, with secondary glaucomas. It's usually something you can see if you look closely at something that is there, but is usually overlooked, as you said. So I'm pretty happy with your topic. I just have one comment for you.
Thank you.
When your topic is really about visual signs, you need to make an effort to get very high resolution images, because your talk is basically about very subtle signs, correct? So you have to get very high resolution, very high quality images. So on the technical side of things, when you're preparing such a talk, a very nice talk about subtle signs, if you have the facilities at your workplace to get your own images, that's great. But if you don't, you're going to have to surf the net for very high quality imaging, maybe from the American Academy website or other atlases out there, to get your points across. So, for example, with the anterior vitreous picture, the signs were not that obvious, for example, with the venous pulsation as well. I like the picture, for example, with the RBCs in the conjunctiva, which is something I usually look at when I'm assessing a bleb, for example, whether it's a filtering a bleb or not. You find these clear circles in between the RBCs, which is basically the aqueous. So this is really the very fine art of anterior segment exam. So I commend you for your presentation. A little bit of technicalities can be worked on, but thank you very much. I enjoyed it.
Thank you so much. I agree with you that I should do better work regarding the quality of images. I do not have, yes, the facilities, but it is not an excuse. So thank you very much. I appreciate your comment. Thank you.
This is the aim of this particular event. It's to upgrade your speaks for later on, inshallah. Thank you.
Thank you so much.
I really appreciate the comments of Ustaz Dr. Mahmoud Shtewi and Ustaz Dr. Sana Mohsen. Very valuable input. And thank you, Dr. Muhammad Al-Imari, for the nice presentation. Now, we would like to move to the second presentation. Khadija, are you with us, Khadija?
Yes.
Thank you. So please start sharing your presentation. Khadija Bazara will talk about ergonomics in ophthalmology. Dr. Zahra Abd Shakur and Dr. Khalid Al-Arfaj will discuss with her. And you can start. We can see now your presentation. You can start. Bismillah.
Okay, thank you. Good evening, everyone. I would like to thank everyone here and thank our panelists for their valuable time and for their being with us and supporting us. This is Dr. Khadija Bazara, General Ophthalmologist from. My topic will be about ergonomics for ophthalmologists. Ergonomics is the practice that involves arranging the environment to fit the person in it. It's also this sign and the art fitting the job and workplace workers need. When ergonomics applied correctly in the work environment, visual and physical discomfort are reduced. There are three types of ergonomics: physical, which is human body response to physical and psychological workloads, such as repetitive strain injuries; cognitive ergonomics, mental, from workloads such as decision-making and human errors and training; organizational ergonomics, policies and processes in the work environment, such as shift work, scheduling, job certification, and supervision. Why ergonomics is important here? Medical professionals are prone to musculoskeletal disorder, with being an ophthalmologist are at a higher increased risk, like disabling back and neck pain, numbness in the hand and the legs, and carpal tunnel syndrome. And the most work-related disabilities in ophthalmologists are caused by simple doing routine, like performing an exam, like slit lamp examination, or using the indirect ophthalmoscope, or even sitting in a surgeon chair. The goals are to reduce the occupational injury and illness and productivity improvement, work quality improvement, also provide safety for the worker and his environment. I would like to mention some of the injuries that affect the ophthalmologist and their solution, starting with neck injury. The ophthalmologist must lean forward the instrument, pushing the instrument and the neck out of alignment, and the head also can move up or down. And you can modify the table to move the slit lamp closer to the examiner than to the patient. The biomicroscope can also affecting the neck. The stationary eyepiece forces the neck into upward flexion and extension for the duration of the surgery. Even the sit-in and table heights can be adjusted optimally, and this eventually can result in damage of the neck and the lower back. So we can use adjustable eyepiece and adjusting an angle of 20 to 30 degrees between the objective and the eyepiece. Using the indirect ophthalmoscope can be taxing on the neck because it entails a specific neck position. For a prolonged period, it also puts weight on the head and awkward neck and spine position to peer through the pupil at specific angle. This is result in moderate flexion and rotation of the neck half of the time, lateral bending of the back most of the time. So indirect ophthalmoscope must be lightweight, adjusting the patient chair so that their head is at the eye level to maintain a good posture. Neck injury can also result from using the surgical loops. It's heavy and requires a fixed range of neck angulation. It can be taxing on the neck and the back, especially with oculoplastic surgery. So try lightweight prism base without incorporated illumination system. And also, or using biomicroscope with objective lens, this can easily provide a larger field of view and increase the work distance. The back injury can result from using the equipments in operating room, because surgeons sometimes neglect to adjust the chair and table to the proper height. Prolonged maintenance of the body in odd position magnifies the strain on the muscle and the tendon. First, adjusting the sitting table equipments so that you can maintain neutral spine with normal curvature throughout the operation, and also using comfortable and adjustable operating chair with back support. Back injury can also be taxing while using the foot pedal. The surgeon sometimes at increased risk of injury if they cannot reach the foot pedal without angling the thighs toward the floor. Lower the seat and the table so that you can keep the knee bent at 90 degrees, the feet flat on the floor and the thighs parallel to the floor, or elevate the pedal on the accessory rise. Arm and hands can get injured because using of the keyboards, because it results from repetitive use of the keyboard. Certain tasks require exertion concentrative forces, during which the hand and arms must work continually. So adjusting the chair, table, monitor, keyboard, and mouse to provide best posture, and sit straight and have your computer screen at the eye level, and this will keep the neck neutral. Here, I would like to mention some facts based on survey done before for the same topic, starting with a survey of vitreoretinal surgeon at 2004, assessing the back and neck pain, and they found that there's around 55% of the surgeon have symptoms, 15% have no symptoms, and around 7% of the surgeon requiring surgery. Another survey of American ophthalmologists in 2005 revealed that there was upper extremity symptoms around 38%, neck and lower back pain around 33%, and around 15% of the ophthalmologists discontinued their work. Another survey of among member of Royal College in December 2015, reporting back and neck pain in about 50.6 and 31.8 of the responders, and there's increased risk of with more surgery-oriented specialties like oculoplastic, anterior segment, and vitreoretinal. A survey of All Indian Ophthalmological Society in August 2017, assessing the prevalence of back and neck pain, and there was symptoms in about 70.8 symptoms percent, and there was 7% of them was interable. And chronic back pain was resulting in a reduction of the time given to the ophthalmic practice, and this is resulting up to 5 hours per week to a persistent pain. A questionnaire was sent to 958 persons, Deutsche Hospital physician, assessing mental disorder, and there was fatigue in about 36%, depression 25%, and anxiety 21%, post-traumatic stress syndrome in about 13%, and burnout in about 5%. So self-rating their current work ability contributes to capturing those physicians at increased risk of decreased work functioning. And lastly, in China, there was a prevalent survey assessing the prevalence of anxiety and depressive symptoms, and they found that in depressive symptoms was about 28%, 25% anxiety, and both in about 19%. Doctor-patient relationship was a potent source of stress. Lengthy working hours and frequent night shift was also a risk factor. Intervention to minimize workload and improving the patient-doctor relationship encourage the physician to develop healthier lifestyle. This will improve their professional performance and health outcome. My take-home message here is ophthalmologists should be aware about this occupational impact around them. They also should be aware about their position and posture throughout the day, taking breaks to stand up and stretches on the surgical days. Performing also yoga and regular exercises can be beneficial. Modification in the clinic and operating room, like adjusting the height of the slit lamp, operating table, chair, and microscope eyepiece. This will maintain the neck and the back in neutral position. Rising the doctor to the patient ratio and reducing the workloads in ophthalmologists are important. And at the end, physician safety is patient safety. Thank you. Those are my references.
Okay, thank you very much, Dr. Khadija, for the nice presentation. Now we will open the discussion. Dr. Khalid Al-Arfaj, please.
Hello, you hear my voice?
Yes.
Yeah. I really congratulate Dr. Khadija for choosing really a good subject like this. We are really aware of the impact of the heavy load of an ophthalmologist. I have seen two of my colleagues, one of them is one of my teachers, having the cervical disc, and we all know about the burnout syndrome, and some anxiety and depression could affect some of the colleagues. So I enjoyed very much your talk. You clearly gave the message, and I like it very much. This is out of the box. I mean, a lot of scientific subject. I don't know. Do you hear me?
Yes, clearly.
Yeah. So this subject really important to us to hear about. My comment about is you were reading the statements in each slide. I was expecting you to put some pictures at the beginning of your talk, and your talk about it. You were labeling the statements and reading it out of the slide. Yes, definitely we know the message, but I was expecting that you involve some pictures and you talk immediately about them, rather than just reading the statements in front of the pictures. Otherwise, also, you did not talk much about the burnout syndrome, depression, and anxiety, except the two studies you mentioned in China and Dutch, and you mentioned high prevalence of such affection, the ophthalmologist. But we're expecting to talk a little bit, or 1 or 2 or 3 slides about these really important subjects about the anxiety, depression, and burnout syndrome, which really affects some of the ophthalmologists. These are the 2 comments I want just to mention. Otherwise, I really enjoyed your talk. Thank you so much.
Thank you very much, Dr. Khalid. I think Dr. Zahra is not here, so I'm going to take the role of Dr. Zahra to discuss with you. Dr. Khadija, where are you?
Dr. Mazen,
yes.
Just for a new practice, what do you think about the depression, anxiety, and other, especially for those of having a lot of heavy load? And what's the solution? If we get the Dr. Khadija, otherwise we want to hear from you your input in this.
Yeah, very good. Thank you very much for asking me this question. Actually, two parts. The spiritual part that I'm not going to talk about it. Everybody knows about it. But the other part is the physical one. I found a solution for myself to go to the gym 2 to 3 times a week. So, and every time I spend 1 hour. The gym gives physical movement to the joints, and at the same time, emotional relief. And you keep finding yourself improving, and you feel that you are maintaining your youth. So this is my way.
Yes. I agree totally with you, brother, Dr. Mazen, that we need to go out of the work environment and really help to maintain our health as much as possible.
No problem. So thank you, Khadija, and thanks to Dr. Khalid for the discussion. Let's move to Dr. Hashim, speaker number 4, Dr. Hashim. Dr. Hashim Abu Sarhan,
Hello everyone.
Yes, he will talk about eyes glaucoma, and Ustaz Dr. Mahmoud Shtewi, Ustaz Dr. Tariq Al-Dais will discuss with you. Please start.
Okay, hello everyone. This is Hashim Sarhan. I am first year ophthalmology resident at Hamd Medical Corporation. I'm very thankful to be with you today. I'm going to deliver a little bit different talk. Eyes glaucoma, the title is glaucoma originated from snacks, and oma is a Latin word that means mass. So it's a mass of snacks, short, unique facts or stories in ophthalmology. First of all, it's spelled ophthalmology. If you don't get that part right, nothing else you do really matters. Nobel Prize in Ophthalmology. Dr. Oliver Goldstrand is the only ophthalmologist who received the Nobel Prize in Medicine 1911 for his great invention, the slit lamp. The funny thing that he was in competition with Albert Einstein, and he was the one who won the prize. In the same regard, Dr. Gouls Gunin was a professor of ophthalmology who pioneered the procedure of ignipuncture, the first successful retinal detachment. He was seriously considered by the Nobel Committee in 1993 for the prize. A questionnaire was sent to ophthalmic authorities around the world. Among all of them, they replied with approval, with only one exception, that they believe that have come from an envious fellow countryman who argued the committee to postpone the award for 1 year. However, Gunin was died in the same year before the next prize was awarded. So the lesson is envy is always a declaration of inferiority. Marcus Gunn, Joe winking, or they say trigeminal-oculomotor synkinesis. It's an abnormal connection between the motor branches of the oculomotor and the motor branches of the trigeminal and the oculomotor nerve. So it's an abnormal connection between the upper eyelid and the mouth. And this explains why when you examine patients with slit lamp and ask them to open their eyes, they open their mouth instead. And also explain why you see females when they do mascara or makeup, they try to open their eyes, but actually they open their mouth instead. Sunglasses sign, one of the common beliefs among the public is that blind people usually wear sunglasses to their eye. An interesting paper was published in Neurology 2008. They found that the probability that a patient walking in a neuro-ophthalmology clinic had non-organic visual loss was 0.04, and this probability increased to 0.8 in patients wearing sunglasses, and the specificity for this sign was 99%. And they found that 96 of these patients who wearing sunglasses were found to review of system workers' compensation claims and disability. One of the interesting recently published papers in BMC ophthalmology, they discussed the impact of cataract on color perception. They reported that cataract significantly interfere with the colors saturations on the retinal image. I heard one of the surgeons propose a new sign for cataract patient, SOX sign. He claimed that if you see a patient with different SOX colors in an ophthalmology clinic, you may consider him as or she as a cataract patient. Kulthum is a well-known Egyptian singer. She has been named among the 200 greatest singers of all time. But there is one thing that has caught our eyes. Have you ever thought why Kulthum almost never seen her without her famous sunglasses? Actually, she was suffering from thyroid eye disease. Her surgeons offered her a thyroidectomy with a risk to have hoarseness of voice post-op. So she decided to wear sunglasses to cover the proptosis and save her musical voice. The atropine was first made and extracted from belladonna, Atruba belladonna plant. Belladonna means beautiful woman in Italian. And these atropine-rich extracts were used by Cleopatra to dilate her pupils in hope that she would appear more beautiful. And that's how they discovered the dilatation function of atropine. In the Middle Ages, the eye specialists in Arab countries were named the Kahal. They had a privileged place in the royal household, especially during the Abbasid period. Ibn Ishaq al-Abadi was one of the most popular Kahals in this period, and his book, The 10 Treatises on the Eye, is considered the first systematic textbook in ophthalmology known in the medical history. Now, let us speak up about the godfather of the new cataract surgery, Dr. Charles Kilman, and his great book about his story, Through My Eyes, and this video, historical video about fecal emulsification done by Dr. Charles Kilman himself. Before that, how cataract surgery was. ICCE was the primary surgery for cataract removal before Dr. Charles Kilman era. It has major drawbacks like large incisions with a slow healing, more surgical induced astigmatism, many reported complications like retinal detachment, corneal compensation. So cataract surgery was major surgery that needed lengthy hospital stays and extensive recovery periods and the use of large instruments, and the patient need to wear big goggles post-op. Who is Charles Kilman? Charles Kilman was born in 1930 in New York. He invented fecal emulsification in 1976, and he faced a huge resistance in 1718 until he became an inspiration for overcoming resistance. Actually, what's strange about Dr. Kilman that he's dreamed to be a popular music player and entertainer instead of being a doctor. Actually, this is what he did. He changed his name to Kerry Adam, and his telephone number songs topped up the US radio stations. He also delivered a new dance technique called the twist, but he was shocked when his dance was stolen and cited by another musician, the chubby checker. After his shock, he decided to continue his career in ophthalmology. This became true when he saw the front page of Look magazine, talking about Dr. Irving Cooper and his cryosurgery innovation for Parkinson's disease patient. He emailed Dr. Cooper to use his lab to try cryoprobes for cataract removal. And before the scientific publication of his new innovation, cryosurgery for cataract removal, he was stunned again when he saw a recently published paper talking about cryosurgery in cataract patients. Here in Manhattan Eye and Ear Hospital, the history changed in 1963. He received a 3-year research grant to propose a method for removing cataract through a small incision, so no hospitalization will be required. He tried many instruments, but he failed. In 1967, the sensational moment for Dr. Charles was made by the dentist, Dr. Larry. Dr. Kelman went to his clinic to whiten his teeth, and Dr. Larry at that time was using a dental bar with ultrasonic energy to whiten the teeth. He was inspired by him to develop the same technique for cataract removal. He tried his new technique on a blind eye. The surgery took 6 hours, and finally he destroyed the eye without any success. He kept trying until he succeeded in the 4th attempt. Kelman named the procedure phacoemulsification, and the Cavitron was designed the first aspiration and irrigation system. He began teaching the courses and spread his new technique to the surgeons. However, phacoemulsification at that time faced significant criticism in the 1917s and 18s. The National Eye Institute labeled the procedure as experimental malpractice, and you may lose your license because two main critiques. The first one, significant corneal damage. In fact, Dr. Kelman said that you need to destroy 40 corneas before learning the technique. And the second critique was the need to enlarge the incision again to load the IOLs, because at that time we don't have foldable IOL. However, this issue was overcome when Dr. Thomas Mazzacco invented the silicone IOL in 1984, what became known as Mazzacco Taco. Could be folded and inserted in the small incision used for phaco. After that, phaco started becoming the norm. So being far ahead of your time is different from being wrong. Dr. Akahushi holds the world record for cataract surgery fastest time. He completed the entire case in just 1 minute and 20 seconds using his karate pre-chop technique without the need to sculpt or groove. You just use this technique and eat the cataract material directly. And this is lastly how eye doctors open yogurt boxes versus normal people. This is just a funny video. And the take-home message: never throughout history has a man who lived a life of ease left a name worth remembering. Thank you all.
Great. Thank you very much, Dr. Hashim. And now we will open the discussion. Dr. Tariq Dais, please. Unmute yourself, Dr. Tariq.
Now my sound is clear.
Yes.
Thank you, Dr. Hashim. Nice presentation behind science. All dentists complain of when you ask patient to open mouth, they open eyes, and reverse for eye. When you tell patient to open eyes, they open mouth. Marcus Gun for all patients. Second, dark glasses is for Kulthum is one of the indication of orbital decompression. When your patient mask proptosis by dark glasses, they need surgical decompression. I would like to ask one question behind science. All invention are male. Jones, Zeiss, Marcus, Hashimoto. What is the woman ophthalmology for invention?
Actually, I don't know, but what I know about women is that now the American Academy CEO is a woman. However, I think males, they have more powerful intention to do the risky surgeries in comparison with to females. I think this is the reason.
Okay.
Okay, thank you, Dr. Tariq. Ustaz Dr. Mahmoud Shtawi.
Dr. Hashim, very nice talk. Give us the history. I know Kelman, when I was in Ireland back in 75 or 76, he visited us, and at that time, he having a hard time introducing phaco to the world. But it is very nice topic. I don't have much to ask, but that's quite a historical presentation. Thank you very much.
Thank you, Doctor.
Okay, super. So we thank you very much, of course, Dr. Tariq Dais, Dr. Mahmoud Shtawi for the discussion, and thanks as well to Dr. Hashim for the nice presentation. Now we will move to the second part of the session. Dr. Khulud, you are with us?
Yes, Dr. Herman.
Okay, now please start your presentation. Meanwhile, Dr. Khulud Farouk will talk about learning from mistakes, and Ustad Dr. Khalid Larfaj, Ustad Dr. Suzanne Quttan will discuss with you.
Thank you, Dr. Mazen. Thanks for this honor and introducing my presentation in front of the honorable panelists. This is a case report from my clinic. History: a female patient aged 53 years old came to clinic seeking an ophthalmology report for her neurologist. She was in a hurry to catch her neurologist appointment, as usual. She pushed to do only fundus examination and take off rapidly. But I assured her that the examination won't take time. I must do my full examination. She told me that she is doing this report because she will undergo shunt operation to treat her unresponsive papilledema. So in my examination, she was wearing glasses. Her best-corrected visual acuity was in the right eye 0.8, in the left eye was 0.5. In the intraocular pressure was measured at 8:30 p.m. The right eye measured 16 and the left eye was 15. The pupil reaction in the right eye was normal, but the left eye showed relative afferent pupillary defect, which was abnormal to me in case of papilledema. So I pursued to fundus examination. The right eye showed normal macular and optic nerve head appearance with normal periphery, but the left eye showed normal macular appearance with optic disc swelling grade 3 with partial color. So what's wrong? Why she has RAB and she is telling that she has papilledema? So I retake history again. I started asking her what was the problem. She reported severe headache, didn't resolve with medication 5 months earlier. She sought ENT consultation, told her she had migraine. She took migraine medication, but with no improvement. She then sought cardiologist to check her blood pressure, that maybe it is the cause of the headache, which was normal, and her heart condition was perfect. Then she went to an ophthalmologist. He examined her and told her to do a fundus fluorescein angiography. The patient refused to do the fundus fluorescein angiography as she was hearing about the complication from the fluorescein intravenous anaphylaxis and so on. In Egypt, there was some troubles with that. So she did colored fundus photo instead. And she was mentioned to do this colored photo if the fluorescein wasn't available. So in this fundus photo, the right eye showed a normal disc with normal macula, but the left eye showed the disc swelling as I saw in my examination, and then macula is normal. Okay, the ophthalmologist wrote a report. The report said that the visual acuity was aided 0.9 in right eye and 0.9 in left eye, which gave me a hint that this is a decreased visual acuity. The intraocular pressure was not different from my examination. The fundus showed left anterior ischemic optic neuropathy swelling, in his opinion. But he told me that the pupil was reactive in both eyes, which is in conflict with the anterior ischemic optic neuropathy. So he wrote in the last that the left was optic disc swelling, grade 3, suggestive of anterior ischemic optic neuropathy. Why with the photo of the fundus that she did. But the left eye, right eye is free with no papillity. So what's wrong? He told her that there is no solution for her case, as he diagnosed it as anterior ischemic optic neuropathy. The headache didn't resolve, and so she continued for a neurologist. The neurologist examined the color fundus and old report and sent her to MRI. The MRI report came normal, but the MRI here was towards the brain examination to exclude the manifestation of space occupying lesion in the intracranial space. It came normal. So she took treatment as a CSF pressure increased, and he told her that she has papilledema and took acetazolamide with potassium. She felt a little improvement that made her to continue the treatment for 4 months, hoping to get fully recovered. But she complained the continuation of the headache despite the treatment she took, and also complained from the complication of the treatment she was taking, the acetazolamide. The doctor arranged to do a CSF opening pressure and another ophthalmological consultation to arrange the shunt operation. So she came to me. I asked for the MRI images itself and not only the report. And here was the surprise. The surprise was a retrobulbar intraorbital mass around optic nerve of the left eye was found and missed from the radiology report. As we can see here, the mass is a fusiform in shape. It's in direct contact with the eyeball, and it's more suggestive of meningioma, optic nerve sheath meningioma. So the diagnosis is not a papilledema nor anterior ischemic optic neuropathy. It's a long-standing compressive optic neuropathy, and most probably a meningioma for further confirmation. The decision by me was to refer her for a neurosurgeon and ocular oncologist for further assessment. The patient repeated the MRI, but with contrast by her neurosurgeon, and the interpretation was the left orbital intraconal enhancing mass, dimension 1.8 multiplied by 1.3 centimeter, inseparable from the optic nerve with mild underlying proptosis. The optic nerve meningioma is mostly suspect. Ford dedicated another MRI orbit, but with no space occupying lesion in the brain. So this is most probably the diagnosis is optic nerve sheath meningioma. Optic nerve sheath meningioma is a rare, slowly progressive benign meningioma. It represents 1 to 2% of all meningiomas in the brain, but it is the second most common primary optic nerve tumors. The incidence is triple in women than men in the 4th and 5th decade. It originates from meningothelial cells, which proliferate circumferentially around optic nerve and spread along it to enter intracranial space. It's rare to turn into malignancy, but it's shown high rate of recurrence. The clinical picture can be asymptomatic if it's very early, to symptomatic with progression of the tumor. The unilateral, slowly progressive painless decrease of vision could range from 20 to 50 to no perception of light, with evidence of optic nerve dysfunction, as we mentioned in our case earlier. Here was the afferent pupillary defect was measured and was noticed. Diagnostics are the CT brain, and the MRI. But the MRI, contrast, and fat suppression is the recommended. The management could range from observation to radiotherapy, and last option is surgical intervention, which we don't like it because it may have a high risk for vision loss. Recently, the 3D conformal stereotactic radiotherapy is the management and treatment of choice. So my take-home message here is don't be dragged to your patient's demand. Make your full examination and don't depend on others. Taking good history is halfway to solve any case. And when suspect, you can repeat the investigations and don't rely on reports only. Thank you very much.
Thank you very much. And just a second. A nice presentation, and let's open the discussion now. Dr. Khalid Al-Arfaj.
Dr. Khulud really present a nice presentation about a dilemma case, that a misdiagnosis case. I mean, went through a lot of ophthalmologists and radiologists, and they did not reach the diagnosis, maybe because of busy practice and not digging very much on the history as well as the reports. I congratulate you that you gave clearly the message that whenever the case is really dilemma and is not responding, and the chronically going from doctor to doctor, ophthalmologist to others one, you try your best to give more time to reach the diagnosis. The problem here, sometimes we copy our colleagues' notices and diagnosis, and we carry on treating the patient sometime in the wrong direction. So your talk, the message and the representation is clear that you should depend on yourself and reaching the diagnosis. You might really reach something else. Some of the cases I saw in my cases, the referred case of diagnosis of keratitis or so, and I saw something totally different diagnosis when I go ahead and dig in the examination and history as well. So I congratulate you to give us the message, but I don't agree maybe with you with the correlation of the subject of the case. You say this is learning from mistakes. You might improve the subject to correlate to your case of having a misdiagnosed cases, or choose more subject can correlate to the case you presented. Thank you so much. Otherwise, you did a great job. Yep.
Thank you, Dr. Khalid. I meant by learning from mistakes that I'm not learning only from my own mistakes. I am learning from others' mistakes, as you have said, that I should pay attention to the history. I should pay attention to the signs. As Dr. Mohammed Al-Amari earlier talked about the early signs, we should pay attention to every sign that could be a lead and clue to our diagnosis. Here was missed by my colleague the relative afropupillary defect. But when I noticed it, it gave me a clue that it can't be a papilledema. It is away from being a papilledema and away from being ion in cases of the some sort of visual acuity was not that bad to become anterior ischemic optic neuropathy.
Because even if you wanted to send me everybody's passport back,
somebody is talking in other speech. Dr. Khulud, you really gave a very nice talk. Thank you so much.
Thank you, Doctor.
Thank you, Dr. Khalid. Dr. Suzanne Quttan.
Assalamu alaikum. Dr. Khulud, thank you for your presentation. Thank you for your subject. You chose a brave subject to talk about. We all may miss some signs sometimes, And that's what, because we sometimes just depend on others' decision or other investigation. The home message that you gave us, I think the most important one, it was don't look at the reports. Look at the photos by yourself. In fact, sometimes the reports may overlook because the order for the investigation was not the right request. Let's say you are the request was MRI for the brain. If they add MRI for the orbit, they can find that tumor. So sometimes writing the request not in a right way may lead the radiologist to do just what we ask him, and he will overlook, not because he didn't see the tumor. So it was a great finding. You help the female. But one question, if we say papilledema, can we decide that this is, or we can give diagnosis of papilledema if it is a unilateral disc swelling?
Well, it's highly uncommon to get papilledema unilateral. It may be early that one eye is preceding the other eye, but it is highly uncommon because papilledema is a unilateral disease. Here to confirm the diagnosis of papilledema, we should do also MRV to detect any occlusion in the sinuses in the brain. The occlusion may also give a point that it can be a case of papilledema that we will develop in the other. But it is unilateral, it is highly uncommon.
In which case we can find a unilateral?
Unilateral papilledema. I think in cases of major blockage in the cerebral venous sinuses in one eye. Same, for example, if the left eye is affected, if the left sinuses are affected majorly, it could be in the left eye. Although it can have a lighter effect on the right side also.
Okay, one question. Did you saw any proptosis? Because the MRI written there is a mild proptosis.
In clinical examination, I didn't notice the the proptosis, but here it's mild because it can be measured by the MRI. It can be more applicable and more to be defined.
Okay, thank you.
Thank you, Dr. Suzanne.
Thank you, Dr. Khalid. Thank you, Dr. Suzanne, for the discussion. Thank you, Dr. Khulud, for the nice presentation. And now we will move to speaker number 6, Majd Al-Tam. Majd, you are with us?
Yes.
Okay. Would you please start sharing your presentation? Majd will talk about gene therapy in ophthalmology. Dr. Mahmoud Shwail and Dr. Tariq Dais will discuss with you.
It's sharing now?
Yes, but not yet. Yeah. You can start. Bismillah.
Okay. Assalamu alaikum, everyone. My name is Majd Al-Tam, an ophthalmology resident from Yemen. Tonight, I'm going to talk about promises and challenges of gene therapy in ophthalmology. What is the advantage of gene therapy over pharmacological approaches? And are we ready now for gene therapy? Why do I choose this topic? Because Yemen has a higher number of genetic disease. Because of relatives marriages is still in high rate. Examples of ocular genetic disease like retinitis pigmentosa, Stargardt disease, keratoconus, and corneal dystrophies. The first discussion of gene therapy is believed to has been led by Marshall Nirenberg, who was the winner of Nobel Prize in Physiology in 1967. Nirenberg wrote a paper about programming cell with synthetic messages that envisioned the potential advantages and dangers of the procedure. The growing success of gene therapy trials and experiences led to the European approval of first gene therapy in 2012, Gilebra, for the treatment of lipoprotein lipase deficiency. But there was unfortunately withdrawal in 2017 because the drug was too expensive. In 2017, the US FDA approved to gene therapy, Kymera for acute lymphocytic leukemia, and Luxturna for RBA65 associated liver congenital amaurosis. Let's see how gene therapy works. In figure A, gene therapy may be carried out by first removing the cell of interest from patient and subsequently reintroducing cell that has been reappropriately genetically modified. Or genetic material can be directly introduced into target organ or tissues of patient. There are several mechanisms of gene therapy, like gene augmentation, which means replace a disease-causing gene with a healthy copy. Gene targeting, which means introducing a new gene, or inactivate a disease-causing gene. Genome editing or correcting therapy means modifies or correct a muted gene. With the recent advent of CRISPR, has proven that gene editing could be performed in a relatively simple and cost-effective manner. Why the eye? There are several reasons for the advantages. Easily accessible, enables rapid and progressive examination. A small size and enclosed structures, which means requires a low doses of delivery vector. Immune privileged means retinal blood barrier prevents a leakage of vector into systemic circulation. Highly compartmentalized, single gene mutation causing disease has been identified. Recent advances in gene delivery system as adeno-associated viral vector. The milestone started in 2007 with liver congenital amaurosis trial. In 2011, clinical trial of retinal gene therapy for multiple inherited retinal disease like Stargardt, retinal pigmentosa, and others. In 2012, clinical trials of gene therapy for Usher syndrome type 1 begins. In 2014, clinical trials for X-linked retinoschisis begins. In 2015, clinical trials for achromatopsia begins. In 2017, FDA approval of first gene therapy for ocular hereditary disease. The geographical distribution, notably, most conducted studies in USA. Most are for hereditary ocular disease like Leber congenital amaurosis, Leber hereditary optic neuropathy, and retinitis pigmentosa. To date, adeno-associated viral vectors, which are part of non-viral vectors, are most used, especially adeno-associated viral type 1. Association Research of Vision and Ophthalmology 2023 has abstracts that there are new way of gene administration like exon editing, large size capacity beyond adeno-associated virus, editing RNA, not DNA, which means there is no long-term impact on DNA or gene, lipoprotein nanoparticles, which are part of non-viral vectors. The application for hereditary ocular disease, Leber congenital amaurosis, choroideremia, Leber's hereditary optic neuropathy, retinitis pigmentosa, achromatopsia, X-linked retinoschisis, and Stargardt disease, Usher type 1B syndrome. All of these ocular hereditary disease are still in studying for effective gene therapy treatment. The above mentioned disease using adeno-associated viral vector, but Stargardt disease and Usher type 1 using letinovirus, because both diseases has a large gene. The hereditary ocular diseases open the space in front of non-hereditary disease like open angle glaucoma, neovascular AMD, diabetic macular edema, which these diseases particularly for whom current therapy are effective but not suitable for long term. Types of vectors, we have viral vector and non-viral vectors. Viral vectors difficult to produce or produce a low virus titer. immune reaction for viral vectors, and limitation in packaging capacity. Non-viral vector, simple to produce, low cost, low immune reaction, and high packaging capacity. These are types of deliveries, which includes intraviral, subretinal, and suprachoroidal. Obstacles to application: mutation identification and molecular diagnosis, safety risks, safety and risk of gene therapy because of the fear of insertional mutagenesis, viral vectors immune reaction, and oncogenesis. Gene therapy for early intervention, because later stages of the disease means there are irreversible damage and there is no benefit of gene therapy. Long-term efficacy of gene therapy, cost of gene therapy, they are still too expensive. Challenges and controversial, technical limitation, unintended gene mutation, off-target effects, potential for misuse of this technology. Ethical, legal, and social implication, human germline editing, or China genetic modification of human embryos trial. Gene delivery needs sustained expression of therapeutic gene and long-standing clinical benefits. Immunogenicity, viral vectors limiting the effectiveness of the therapy. Early disease diagnosis, choosing the optimal timing, and long-term efficacy all are contributors to the difficulty in translating gene therapy from the bench to the bedside. Future perspectives, genome editing techniques such as CRISPR-Cas or exon editing therapy have renewed the hope. Ongoing studies investigating the optimal ophthalmic drug delivery vector, including non-viral modalities. Investigating methods for controlling the off-target effects of genome editing. Conclusion, gene therapy has the potential to revolutionize the treatment of ocular disease, but ongoing research needs ongoing research and development are necessary to overcome the challenges and bring these therapies to patients. Ocular gene therapy offers promising potential to treat various inherited and acquired eye disorder. However, it poses significant challenges such as delivery and safety issues, scalability, and affordability. The ability to customize therapies based on patients' genetic profiles is a significant advantage. And these are my resources. Thank you.
Thank you very much, Dr. Majd, for the nice presentation. Dr. Mahmoud Shuwair.
Thank you, Dr. Majd. That was an excellent presentation for complicated topic, but it's very important in our part of the world, as you said, because of the consanguinity. So the rate of genetic diseases is actually, in our part of the world, is considered to be one of the highest in the world. So I just want to comment on a few things, and this probably we are trying to refine the presentation here. I'm not honestly, this falls out of my area of expertise as a cornea and anterior segment surgeon. However, I just want to give you a few comments on the presentation that probably might help just refine the presentation. So I've noticed that some of the slides are full, so they have a lot of material. And in the beginning, you were actually doing much better. So you were commenting, so you're putting pictures and commenting, and that actually excellent. So it will attract the attention of the people who's hearing. But probably fall back into the habit at the end of reading the slide, and whenever you start reading, so even the person who's listening to your presentation, I can do the reading, but it's just I wanna get the input from you as a presenter. So it's usually recommended that you don't, even if you want to say a full sentence, just put the headline, or at least the beginning of it, or put something on the slide that will remind you what to say. And then rehearsal. You just go and rehearse and practice the presentation multiple times and know exactly the point of memorizing what you want to say, instead of putting it into a slide and making it very jam or like busy slide. So that the problem with that is that you lose your audience when people, now I know that you're probably getting around this by making animation and it's coming one by one, which is good. It's better than the whole slide. However, the step that I want you to take further is to train yourself that just have just the beginning or a headline. You can, especially now, like you're not presenting in front of us, so you can use, there are in PowerPoint, there is a presenter tools, and the presenter tools, when you hit that, you will see the notes. Down in the PowerPoint, there is parts that you can write notes for you, or you can write it in a piece of paper. So you don't have to write everything there. That's probably the the biggest comment that I have, and then the second comment is probably about the grammar. There are a few grammars that probably need. It's just we are looking here for perfect. We want to perfect your presentation, so few grammars mistakes that need to be looked at. But overall, I really congratulate you on the presentation. It's a very nice presentation and a topic that is much needed.
Okay, thank you, Dr. Mahmoud. Dr. Tariq.
Okay. Thank you, Dr. Majd. Nice presentation, nice topic. Gene therapy is the future in ophthalmology. I also nice comment from Dr. Mahmoud. I would like to ask, what are the potential challenges about gene therapy for bring to the market, rather than it's very expensive?
There are multiple challenges. First of all, mutation identification, which means early diagnosis of the muted gene that causes the disease, means we need a more advanced facilities and modalities to diagnose this genetic disease that we are searching, or that we are trying to treat with gene therapy. So the modalities, the advanced modalities or molecular diagnosis, one of the challenges for this topic.
Are there any Arab country treat gene therapy?
Saudi Arabia is one of the country who started earlier in trials for clinical trials for ocular hereditary disease, and I think in last April, Egypt tried Luxturna for a 9-year-old patient with inherited retinal disease, Leber congenital amaurosis. So Saudi Arabia and Egypt.
Thank you.
Okay, great. Thank you very much, Dr. Tariq and Dr. Mahmoud, for the discussion, Dr. Majd for the nice presentation. Now we will move to the last presentation. Dr. Aisha Al-Mikhlafi will talk about trauma in ophthalmology. Dr. Aisha, you can start sharing your presentation, please.
Okay.
Dr. Saeed Al-Himyari will discuss with you. Dr. Zahra supposed to be here, but we can see who can take the role, or maybe me. So you can start, please. Thank you.
Okay, thank you. Bismillah, assalamu alaikum. Good evening, everyone. It is an honor and a pleasure to be with you here. I'm Dr. Aisha Al-Mikhlafi. I am from Yemen. I'm a specialist in ophthalmology. My topic will be about trauma in ophthalmology, which is a topic, whatever your subspecialty, you must know. Trauma is a leading cause of unilateral visual impairment after cataract. First of all, I'll be talking about, is it clicking? Okay, first of all, I will be talking about the classifications of eye injuries according to the Birmingham Eye Trauma, which classified the eye injuries into closed globe, which is due to there's no full thickness, which is contusion and lamellar laceration, and the open globe, which is full thickness. Classified into rupture, which is due to a blunt object, and laceration, which is due to a sharp object. And lacerations are divided into penetrating with an entry wound only, and perforating with an entry and an exit wound. Before talking about history and examination, we have to make sure that the patient is cleared from any life-threatening conditions by the primary survey by an ER doctor. Then we will take the history, which is divided into regarding trauma itself and the medical history. Regarding the trauma, the onset of the trauma, the mechanism, is it low or high velocity? What is the type of chemical agents? Is it acid or alkali? And the material of object. Is it inert substance as glass, stones, plastic, which are more durable than metallic foreign bodies as copper and iron? The medical history, the medical disease, surgical history, and medications. Then we go to the examination. Before I touch the patient, we have to rule out globe rupture. And we test both the affected and non-affected eye. We observe the orbit, we see the visual acuity, the extraocular movement, the pupil. Is there any relative afferent pupillary defect? And we see the anterior and posterior segment. And then we use the imaging tools, the ultrasound, the CT, and MRI. And we should take an opportunity when taking the history to educate the patient about the importance of wearing protection eyewear, about the dangers of toy guns, about the importance of irrigation in chemical injury, and also document our case with a photo. First, I'll start with the chemical injury, which is irrigation is a top priority. Once the patient comes, we start irrigation even before the history. We use normal saline. If it's not available, we can use tap water. We use a topical anesthesia to facilitate our irrigation. We let the patient look in all directions, and we sweep the fornices. We have alkali and acids. Alkali are more dangerous as they penetrate deeper due to their liquefaction necrosis. And acid has a coagulation necrosis as it causes a barrier for more penetration. Alkali, like we have the cement, we have the fertilizers and substances that contain ammonia, and the acid as car batteries, as vinegar, as bleach. We have the Roper-Hall modification, which graded the chemical injuries into 4 grades according to the limbal ischemia and the corneal involvement. Grade 1, there's no limbal ischemia and there is epithelial damage. Grade 2, the limbal ischemia is less than 1/3 of the limbus, and I can see the iris details. Grade 3, from 1/3 to half of the limbal is ischemic, and the iris details are obscured. Grade 4, the limbal ischemia is more than half of the limbus, and the cornea is opaque, and I cannot see any iris details. Like in this case, we see in this picture, there is limbal ischemia that is half of the limbus, and I can see the iris details. So this is grade 2. In grade 1 and grade 2, the management of chemical injuries is preservative-free lubricants, steroid, topical antibiotics, cycloplegic agents, and if the and we give anti-glaucoma. In grade 3 and 4, we give medications that help promote the healing and prevent ulceration, a sodium ascorbate, doxycycline, autologous serum drops, and temporary amniotic membrane. Then we follow the patients for chronic complications as entropion, ectropion, sembaliflurone, cataract, and glaucoma. Hyphema is due to disruption of the blood vessels that support the iris and the cellular body. And we have gradings, microhyphema that is seen only by slit lamp. Grade 1 to grade 4, it's according to the amount of blood in the anterior chamber. In this picture, we see it's grade 1 as it's less than 1/4 of the AC. In this picture, we see a total hyphema, and there's corneal staining and increase in intraocular pressure. This is an 8-ball hyphema. How do we manage the hyphema? We tell the patient to rest and head elevation, eye shield, to prevent further bleeding. Avoid the non-steroidal anti-inflammatory drugs as they have antiplatelet activity. If the patient has nausea and vomiting, we give antiemetics, we give cycloplegic agents, we give steroid anti-glaucoma agents. Indications of surgical evacuation: if the intraocular pressure is more than 25 millimeter mercury, more than 5 days, or more than 60 millimeter mercury, more than 2 days, if there is corneal staining, or if the patient has immunoglobinopathies, sickle cell anemia. Corneal abrasions: this is injury to the corneal epithelium. We use fluorescein to see the abrasion. This case, in this picture, we have the ice ring sign, which is multiple linear corneal abrasion. This means that the foreign body is in the upper lid, so I have to avert the lid, and also look for other foreign bodies if present. We see the corneal sensation, give lubricants, topical antibiotics, and cycloplegia. Blowout fractures: this is due to a blunt trauma. This is due to an impacting object which is larger than the orbital aperture, which is more than 5 cm. And this leads to increase in intraorbital pressure, leading to fractures in the orbital bones, mostly the inferior and medial bones. And the clinical pictures, as this patient, we see lid ecchymosis. There might be surgical emphysema in ophthalmos. The pupil might be dilated in optic neuropathy. There might be extraocular muscle restriction and hyposthesia of the upper lip and the cheek. This means that there's injury to the infraorbital nerve. We order a CT in these cases. As in this case, we see an inferior orbital floor fracture and herniation of the orbital contents. We tell the patient to avoid noise blowing. We give cold compressor, nasal decongestant, antibiotics. And if the swelling is, if we want to give systemic steroid for swelling, we have to bear in mind the CRASH study, which indicates that if associated with brain injury, giving steroids might increase the incidence of death. So we have to consult the neurologist, and the patient, if he might need in the future an orbital implant, we consult the oculoplastic surgeon. In globe rupture, this is due to a blunt trauma. The signs are loss of anterior chamber depth. This is seen by Seidel test, as in this picture, and peaked pupil, where the apex usually identifies the site of rupture, which is usually at the limbus or at the site of insertions of extraocular muscles. In globe rupture, we do an eye shield and never ever do a pressure patch, which sadly we see in the ER. We ask for imaging as a CT and an MRI. Corneal laceration: this is due to a sharp object. We have partial thickness. This is managed as a corneal abrasion. Full thickness corneal laceration: if it's less than 2 millimeter, we use glue or a bandage contact lens. And if it's more than 2 millimeter, we give sutures. How do we manage open globe management? We decrease the expulsion of the intraocular contents by giving an eye shield. If it's not available, we can use a cup like in this picture. If the patient is irritable, we give him sedation, we give analgesia. If the patient is nausea or vomiting, we give antiemetics, IV antibiotics, and give tetanus prophylaxis. Then our aim for managing open globe is to restore the normal anatomy, to prevent, to do a watertight suture, and to prevent high astigmatism and scarring as much as possible. We evaluate the laceration before passing the suture. The sutures that we use a spatulated needle, which is passed at 90% of the cornea, not full thickness, so it won't be a route for microorganisms, and not too shallow, so it will cause a wound gape. We use long sutures at the periphery that are close to each other, and short sutures that are centrally and wide apart, so they won't obscure the visual axis. And dealing with prolapse tissue, just do a paracentesis, clean the membranes if there is on the iris, and use a spatula to put it back again. In lead laceration, we have some signs that are important to see. If there's any orbital fat, that means violation of the orbital septum. If there's roundening of the inner canthi or telecanthus, that means medial canthal ligament injury. And we have to see if the canaliculi is involved or not. This is a case I saw a couple of months ago. A 30-year-old male patient presented to the ER 3 hours ago after a stab wound by a jambia. And what we mean by a jambia, this is a traditional dagger that we use in Yemen. His medical history was free. In the examination, I ruled out first rupture globe. The vision was good, extraocular movement was good, AC depth was well, the pupil were reactive, and I ordered the CT scan, which was intact. The diagnosis was lateral lid laceration involving the margin. In the OT, I excluded the open globe again because the full thickness behind it was subconjunctival hemorrhage. So I did a periotomy and saw that the sclera was intact. There was no orbital fat, so that means the orbital septum was intact. I cleaned the wound from debris of the jambia and the lashes, and then I approximated the lid margin with a Silk 40. I didn't tie them. Then I sutured the tarsus with a Vicryl 60, 2 stitches, and then I sutured the skin with a Prolin 60 with the lid margin. There were several studies conducted in Yemen regarding trauma, which concluded that trauma was responsible for 20.2% of unilateral visual impairment. And the most common traumas that we see are vegetative causes, because Yemen is an agricultural country in which many Yemenis are farmers. So we see corneal lacerations, we see traumatic cataract, we see fungal keratitis. Also, due to the war that our beloved country is facing, we see gunshot-related injuries. Also in pediatric population, as toy guns with plastic bubbles and plastic balls and fireworks that are used in celebrations, they are the most common injuries in the pediatric population. And speaking of celebration, I would like to congratulate and give my best wishes and a happy Eid for all of you. Kul aam wa antum bkhair, as Eid is coming in less than a week. My home message is take the opportunity when taking the history and examination to educate the patient. Remember, in chemical injuries, irrigation is essential. Even before taking history, never ever remove an intraorbital foreign body before full examination. Always shield the eye and never apply pressure patch. Plan the management before any step. Assure the patient and do the best you can. These are my references. Thank you very much for listening.
Thank you very much. Now we will open a nice presentation, of course. Now we will open the discussion. So Dr. Saeed, could you please start?
Thank you very much, Dr. Aisha, for this nice presentation. Actually, you are cover most of the subject about ophthalmic trauma, especially we are in Yemen during the last period. I mean, we faced a war, so a lot of cases like this, I mean, we are facing in our practice. My question to you, how often you are using, I mean, intravenous antibiotic prior to ocular, I mean, or rupture globe repair?
Actually, this is done by an ER doctor before preparing the patient for the operating theater. But if he comes to me in the clinic, I don't give IV antibiotic.
So actually, it is controversial, but we want to know that Dr. Mazen is a cornea and refractive surgeon. I want to know if he is, I mean, doing like this, intravenous antibiotic prior to rupture group repair. Have you done, Dr. Mazen?
Yeah, as you mentioned, it is controversial. Usually I don't give. Yeah.
Most of us, we don't give actually intravenous antibiotic prior to rupture group repair because, I mean, blood ocular barrier, and we know it's used as a prophylactic, but for traumatic endophthalmitis, but we don't use it. Me also don't use it, but it is controversial as mentioned. Thank you very much, Dr. Aisha. It was very nice presentation, and good luck.
Thank you so much.
Great. Still, we have 3 minutes. So any of the panelists would like to discuss with Aisha? Okay. Dr. Mahmoud? Dr. Mahmoud, you would like to add something or to ask?
I just wanted to say that it was excellent presentation. She covered most of the ocular emergencies very nicely and was very precise and up to the point. So it was an excellent presentation.
Thank you so much. Thank you, Dr.
Yeah. Thank you very much. So at the end of this session, I would like to thank all the participants for their very nice presentations. And this session actually is unique because it is a cocktail. We have different topics from different subspecialties and general ophthalmology, and many of them were out of the box thinking. So it was very interesting. I would like to thank as well the panelists who gave us valuable time to be with us and evaluate and discuss with the participants, and hope to see you after 2 weeks. Inshallah, have a good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
وعليكم السلام ورحمة الله.
الله يعطيكم العافية جميعا.
Allah يعافيكم. Barakallah fikum. We will be waiting for your evaluation, please. If you can send it privately to my WhatsApp. Jazakumullah khairan. Assalamu alaikum.
Inshallah.
Dr. Mazen, can you send us the form again in the group so at least we have it? Because I know you sent it before. So if you can just, it will be easier if you send it again.
Sure.
Thank you. Jazakallah.
Wa iyyakum. Assalamu alaikum wa barakatuh.